Assalamu alaikum wa rahmatullahi wa barakatuh. Welcome to a new subject of pediatric surgery made easy. Our topics today will be about malrotation in infant and children. Let's start. Intestinal malrotation is very important subject for all pediatric surgeon and pediatrician. Our objective is to understand the embryology behind the intestinal malrotation, explain the different clinical presentation of intestinal malrotation, understand the updated management of intestinal malrotation, and recognize special consideration in a case of intestinal malrotation. At first, the embryology of the intestinal development begins during the 4 weeks of intrauterine life. By this embryological change, the gastrointestinal tract starts as a simple, straight, primitive tube. Then it will be changed into mature and fixed, folded intestine normally present at birth. The primitive gastrointestinal tube will differentiate into foregut, midgut, and hindgut at the 4th week of gestation. The midgut portion forms the middle part of the primitive tube, and it will be supplied with the superior mesenteric artery. The midgut development embryologically passes into 4 stages. A stage of herniation outside the abdominal cavity, and then a stage of rotation outside the abdominal cavity, and then a stage of retraction, and finally stage of fixation. The first stage is called herniation due to the rapid growth and outgrowth of the midgut during the 4th week of the gestational life, so the abdominal cavity cannot accommodate this enlarging midgut, so they herniate outside the abdominal cavity. There will be a primitive midgut loop. This primitive midgut loop supplied with the superior mesenteric vessels, and the superior mesenteric vessels divide this midgut loop into 2 parts: the duodenojejunal limb, or the prearterial part, this part, and the cecocolic limb, or the post-arterial part. The proximal part will form the duodenum, jejunum, and small intestine, and the distal or the post-arterial will give rise to the cecum and the colon. Both limbs will rotate in parallel but separately around the superior mesenteric artery. So the superior mesenteric artery will supply the midgut loop. Number 2, it will act as an axe for midgut rotation. The rotation will be 3 counterclockwise separate 90-degree turn around the superior mesenteric artery. The first turn occurs outside the abdomen, and the second turn occurs during retraction of the loop to the abdomen, and finally the third rotation will occur inside the abdomen. This rotation will result in the normal anatomical orientation of the intestine, with the duodenum and its C lobe posterior to the superior mesenteric artery, and the transverse colon lie anterior to the superior mesenteric artery. This is the final orientation and arrangement of the gastrointestinal tract. The last step is a fixation, retroperitoneal fixation of the duodenum and the colon at about the 12th week of intrauterine life. So the intestinal rotation will result in the DG junction, duodenojejunal junction, will present to the upper abdomen to the left of the midline in this point, and the cecum and the ileocecal region will present on the right lower quadrant. The distance between the DG and the cecum is called root of mesentery. As we see, this arrangement allows for wide distance of the root of mesentery, thus prevent the development of volvulus, development of intestinal rotation around itself. So the arrangement will place the DJ or the duodenojejunal junctions in the upper abdomen to the left of the midline, and the cecum with the terminal ileum in the right lower quadrant. This wide distance in between called the root of the mesentery. This will be the root of or the pedicle for the small intestine. Any of these vital steps can be avoided, means it didn't occur, or reversed, means that rotation occur in a clockwise direction, with the development of a spectrum of disorders encountered clinically and called intestinal malrotation. So, what is intestinal malrotation? Intestinal malrotation, it is anomalies or disorders of intestinal rotation and or fixation. In intestinal malrotation, the mid-gut loop don't complete its elongation or normal rotation. Number two, the bowel is not fixed adequately. Number three, there will be narrow root of mesentery. As illustrated in this picture, this is the cecum and this is the DJ junction. So this red line, small red line, represents the root of mesentery. It will be very small distance between the cecum and the DJ junction. So the small intestine will be more liable to rotate around itself and form mid-gut volvulus. Moreover, there will be a fibrous band attaching this abnormally positioned cecum to the lateral abdominal wall called Ladd's band. These Ladd's bands cross over the duodenum, making compression and obstruction of the duodenum. So in malrotation, the mid-gut loop don't complete its normal rotation and elongation. The bowel is not fixed adequately. There will be narrow base of mesentery, and this make more susceptibility for mid-gut volvulus. When we compare the root of mesentery represented by this small red line to the normal root of mesentery represented by this large red line, starting from the DJ on the upper left midline to the cecum on the lower right of the abdominal side. The rotational anomalies is critically important to the pediatric surgeon, and the clinical presentation will appear when rotation failed to occur or incomplete rotation or reversed rotation. Rotational anomalies or intestinal malrotation may occur as an isolated anomaly or may occur with gastroschisis, omphalocele, congenital diaphragmatic hernia, or small intestinal atresia. There are many types of malrotation since its first description by the Dot in 1923 and Ladd in 1931. Actually, their first presentation included about 8 cases. Later on, many cases were described. Some of these cases or some of malrotation cases are dangerous types, and others are less dangerous types. The main difference will depend on the distance between the DJ junction and the ileocecal valve or the cecum. The longest the distance, the less risk for the development of mid-gut volvulus, and this is called the less dangerous types of malrotation. The distance between the DJ junction and the cecum, as demonstrated in these pictures with dotted line. So this is called wide distance or wide base of the mesentery or wide base of what should be the Treitz angle. On the vice versa, there may be, in some cases of malrotation, the cecum will be very close to the DJ junction with a narrow base of mesentery. This patient will be more susceptible or at higher risk for the development of mid-gut volvulus. What are the common types of rotational anomalies? Rotational anomalies may include Number one, incomplete rotation, non-rotation, reversed rotation, right and left mesocolic hernias. In incomplete rotation, the normal rotation arrested at or near 180 degrees. The cecum will present in the right upper abdomen with associated compressing and obstructing glad band, abnormal band attaching the cecum to the lateral abdominal wall, compressing the duodenum, causing duodenal obstruction. Mid-gut volvulus is a risk due to narrow base of mesentery. The distance between the cecum and the DG junction will be very small, so this puts the small intestine at a risk for volvulus. This is the first type, incomplete rotation. The second type will be non-rotation. There will be a failure of the normal 270 degree of rotation. The DJ limb with the duodenum and jejunal small intestine present on the right side of the abdomen, and the cecocolic limb will present on the left side of the abdomen. Regarding mid-gut volvulus, it differs from one case to another, depending on the distance between the cecum and the DJ junction. So the most important in non-rotation is that the large bowel will be present on the left side and the small bowel will be present on the right side of the abdomen. The third type is reversed rotation, which means that rotation occurs in a wrong direction, 90 degree clockwise rotation. The duodenum will assume an anterior position with its C-shaped will assume anterior position to the superior mesenteric vessels, and the colon, transverse colon, will present posterior to the superior mesenteric vessels. This is reversal of the normal orientation of the intestine. In such cases, volvulus may occur in addition to obstructions of the transverse colon due to trapping of the colon posterior to the duodenum. So we may have incomplete rotation, we may have non-rotation, we may have reversed rotation. And the final one is the paradiudinal hernia. Paradiudinal hernia, actually it is rare, may be due to failure of the right or left mesocolon to fuse to the posterior abdominal wall. So potential space is created and small intestine may become trapped and sequestrated, partially obstructed inside this left or right mesocolic hernia. What are the clinical presentation of rotational anomalies or the clinical presentations of intestinal malrotation? The incidence of malrotation is approximately 1 in every 6,000 live births. Barium study show that there are about 0.2 increase in this incidence. Also, autopsy studies, the incidence may be as high as 1 of the total population. Associated anomalies are common with intestinal malrotation, maybe intestinal atresia, imperforate anus, cardiac anomalies, duodenal web, Meckel's diverticulum hernia, or trisomy 21 associated anomalies. The clinical presentation of intestinal malrotation may be prenatal presentation, or may be early postnatal presentation, or may be late presentation in older child. So we may have 3 forms of presentation. The first one is the prenatal presentation. We mean by prenatal presentation, prenatal volvulus. Prenatal volvulus may be the first presentation of intestinal malrotation, and it will be detected as a dilated bowel during fetal ultrasound assessment due to associated small intestinal atresia, duodenal atresia, or stenosis as a result of antenatal or prenatal volvulus. The second presentation is early postnatal presentation. About 90% of patients present during infancy about 10 to 15% of the patient present during the first year. However, volvulus can occur at any time. There will be a sudden onset of the bilious vomiting in a previously healthy term neonate, which is the cardinal sign for intestinal malrotation. The development of bilious vomiting, sudden onset in a previously healthy term neonate should raise the suspicion of intestinal malrotation until proved otherwise. The early postnatal presentation may be with the sign and symptoms of neonatal intestinal obstruction, bilious vomiting, colicky abdominal pain, abdominal distension, or maybe with the sign and symptoms of bowel ischemia and midgut volvulus, like hemodynamic instability, abdominal tenderness, signs of peritonitis, or blood per rectum. All of these presentation may be present as early presentation of neonatal intestinal obstruction due to intestinal malrotation. The late presentation, usually older child or teenagers present with chronic non-specific symptoms, like failure to thrive and chronic intermittent colicky abdominal pain. Failure to thrive may be explained by intermittent or partial volvulus, which lead to mesenteric venous and lymphatic obstructions with impaired nutrient absorption. This late presentation will be very challenging because of the wide differential diagnosis of these chronic non-specific symptoms of the explanation for the chronic intermittent colicky abdominal pain. So the diagnosis in older child or teenager is challenging because the symptoms are vague, may sometimes seem unrelated to the abdominal cavity, and most commonly the child usually undergone multiple imaging, like ultrasound, upper gastrointestinal imaging, CT, and the MRI, trying to reach the definitive diagnosis of this abdominal pain. On physical examination, early the infant may have scaphoid abdomen or mild upper abdominal distension. However, later on, there may be progressive abdominal distension, peritonitis, abdominal wall erythema, or shock. This is developed as a late sequelae or complications from neglected complete bowel obstruction. The laboratory finding often non-specific and of limited diagnostic value. However, the pediatric surgeon must have high index of suspicion in previously healthy baby who present with sudden onset of bilious vomiting, and intestinal malrotation must be excluded and must be considered the provisional diagnosis until proved otherwise. Regarding radiological diagnosis, the prenatal ultrasound diagnosis or fetal ultrasound may show the sequelae of the prenatal or antenatal midgut volvulus, and the bowel dilatation, meconium peritonitis, or fetal ascites in complicated cases. So the prenatal diagnosis may diagnose consequences of prenatal midgut volvulus by the presence of associated atresia, dilated proximal bowel, or in some cases of, if there is a complication, maybe meconium peritonitis with perforated intestine. Postnatal diagnosis, postnatal radiological diagnosis, which is very important. The first investigation is plain abdominal X-ray film. Often the first imaging of suspected malrotation, lateral decubitus or upright view is obtained. The plain X-ray will assess the bowel gas distribution or the pattern of gas distribution for any neonate or newborn with suspected intestinal malrotation. Usually the X-ray findings are non-specific. Maybe gasless abdomen, maybe gastric distensions with some scattered gas or gasless distal abdomen, maybe double bubble signs of the duodenal obstructions with scanty distal gas, may show bowel malposition in non-rotation cases with a small bowel on the right side and the large bowel on the left side. May show nematosis intestinalis with or without portal venous gas in some cases of complicated intestinal malrotation. So there is a wide variation of the plain radiograph appearance. So one should never rely on these plain X-ray findings to diagnose or exclude intestinal malrotation. However, it is still the first order radiology for infant or neonates with suspected intestinal malrotation. The second one is upper gastrointestinal contrast study, which is most used imaging for diagnosis of intestinal malrotation. It will define the duodenal pattern of the malrotation, and also it will define the position of the DJ junction to the left of the midline on the upper side of the left of the midline. As we see, this is the stomach and the duodenal bulb and the C-shape with the DJ junction to the left of the spine. This is the spine and present to the left of the spine also in this image. The pattern of the duodenal malrotation on the upper GI may be non-rotation of the duodenum. All the duodenum and jejunum remain to the right of the spine. This is the spine, right of the spine, and ligament of threads usually absent. As we see, this is the stomach, duodenal bulb, and all the duodenum and the upper jejunum present on the right of the spine. This is called non-rotation pattern of the duodenum on the upper GI study. Or may show partial rotation of the duodenum. The duodenum don't rotate to the left upper quadrant and usually present on the jejunum, usually present in the right upper quadrant. Ligament of threads may be absent or abnormally positioned. This is partial rotation. Duodenum cannot reach its normal positions in the upper left quadrant to the left of the spine. May show, the upper GI study may show low-lying DJ junction, like this. The DJ junction normally present to the left of the spine at the level of the transpyloric plane. So it may be low-lying the DJ junction, suspicion of intestinal malrotation, or failure of the DJ to locate it to the right of the spine, like this image. However, in mid-gut volvulus, the upper gastrointestinal contrast play an important role. It may show the coil spring or corkscrew appearance of the duodenum, which is diagnostic of mid-gut volvulus, like these pictures or this X-ray and this diagram, or may show paired peak appearance with complete obstruction of the duodenum, indicating that there is maybe mid-gut volvulus. Or may show Z-shaped duodenum and jejunum, like this presentation, Z-shaped appearance of the duodenum and jejunum. So upper contrast study may be valuable to assess duodenal pattern of malrotation, may be partial or non-rotation of the duodenum, or low-lying DJ junction, or may be diagnostic of mid-gut volvulus in a case there is corkscrew appearance of the duodenum, or maybe Z-shaped configurations of the duodenum, or the bird beak appearance with complete duodenal obstruction. In some children, the diagnosis of the malrotation will be difficult on the upper gastrointestinal contrast study because of technical difficulties or difficulties in differentiating normal variation in the duodenal anatomy from true intestinal malrotation. In such cases, the pediatric surgeon will try to locate the site of the cecum, whether by using the contrast fall-through, upper contrast fall-through, or to perform a barium or contrast to perform a contrast enema. The contrast enema, in such case, contrast enema used to locate the cecal position. However, the cecum is normally located in about 15 to 30% of intestinal malrotation. Despite intestinal malrotation, there is normal located cecum. Moreover, many patients with normal intestinal rotation may have an abnormal cecal location due to deficiency in the fixation of the cecum. So there may be abnormal cecal position in infant and neonates, maybe in children. Therefore, the contrast enema is not always helpful nowadays, and the use of the contrast enema to locate the cecum is historically very important. However, today, there is maybe two abnormalities that the cecum normally located in cases of intestinal malrotation, and many patients with normal intestinal rotation has abnormal cecum location. The ultrasound is very important, can diagnose or exclude intestinal malrotation. However, its sensitivity and specificity cannot replace the upper contrast study. Ultrasound finding may show dilated duodenum, may show the inversion of the relationship between the superior mesenteric artery and the vein, or may show what's called whirlpool sign in acute mid-gut volvulus. Normally, the superior mesenteric vein located to the right of the artery. Inversion of this relationship indicative of rotational anomalies. However, this vessel's inversion may be present in normal rotation. Moreover, normal vessels relationship may be present without intestinal malrotation. Number two, what's called whirlpool sign. Suggestive, this whirlpool sign is suggestive of the mid-gut volvulus. However, the sign not present in children with band obstruction without mid-gut volvulus. Number two, the sign may be difficult to assess with mid-gut volvulus and large amount of dilated gas-filled bowel. So the normal superior mesenteric artery and vein orientation with the absence of the whirlpool sign on the ultrasound may provide reassurance that the diagnosis is not mid-gut volvulus may be used in unstable patient cannot perform upper contrast study. However, there is some debates about the inverted relationship that it may be present with normal intestinal malrotation, and also that the normal vessels may be present with intestinal malrotation. Whirlpool sign may be absent in a case, or may be difficult to assess in the case of the severe dilated bowel with gases, may be absent in the case of the band obstruction without mid-gut volvulus. Finally, the cross-sectional imaging CT or MRI may show the dilated duodenum, malposition, internal hernia, abnormal relationship of the superior mesenteric vessels, whirlpool sign. However, these imaging are not commonly performed in children. So the general rule is that intestinal malrotation diagnosed on a clinical ground and pediatric surgeon must have a high index of suspicion of intestinal malrotation in any unit with sudden onset of bilious vomiting in a previously healthy term unit. Then the pediatric surgeon can use X-ray to assess the gas distribution, upper contrast study to detect the duodenal pattern of malrotation, and to assess the presence of mid-gut volvulus, ultrasound assessment for the relationship between the superior mesenteric vessels and the whirlpool sign. However, these are assisting tools for the diagnosis, and the pediatric surgeon must have a high index of suspicion. No more time are allowed to be consumed waiting for this investigation if there is high index of suspicion on clinical ground. How to manage a child with intestinal malrotation? Number one, all symptomatic infant or newborn should undergo urgent exploration. Number two, delayed operative intervention for further confirmatory testing or prolonged resuscitation is not wise. when suspicion is high on clinical ground to avoid the development of catastrophic mid-gut volvulus. Also, there is still a major challenge in older child. In older child, the symptoms usually vague. So if symptomatic, older child should undergo operative correction. However, the families or the family of the child must be informed that older children may develop higher percentage of post-operative complication with higher percentage of free surgery when compared to the small or the young children or the young infant and neonates. So these older children pose a special challenging problem for the pediatric surgeon to decide which procedure will be suitable for every child. The preoperative management will include corrections of fluid and electrolyte imbalance, intravenous broad-spectrum antibiotics, nasogastric decompression, followed by immediate exploration. What are the basic operative principles? The basic operative principles for correction of intestinal malrotation remain unchanged, as it first described by Ladd's and named by Ladd's procedure in 1931 and 1936. The steps can be summarized as follows. After incising the abdomen or after making incision, right transverse upper incision, bowel evisceration is number one, followed by rapid counterclockwise bowel detorsion to save the life of the intestine, then division of the Ladd's band, then straightening and freeing of the duodenum is very important to remove any adhesions and make the duodenum straight, passing downward on the right side. Broadening of the small intestinal mesentery as possible is very important. However, care must be taken not to injure the superior mesenteric vessels. Placement of the small bowel to the right side and the colon to the left side, like non-rotation state, and most surgeons end the procedure with incidental appendectomy due to future mispositions of the appendix if appendicitis occurred later on life. These pictures summarize the steps, some important steps: counterclock detortions of the volvulus, straightening and freeing of the duodenum that descend directly to the right lower quadrant, and cutting the Ladd's band, broadening of the base of the mesentery to act as create longest distance between the DJ junctions and the cecum to prevent the development of mid-gut volvulus. Operative challenge. There is maybe some operative challenge for the pediatric surgeon. Number one, if the bowel is frankly necrotic, small intestine is frankly necrotic, what to do? It should be resected. This is the general rule. However, with long segment of questionable viability, this will be a difficult task. Otherwise, you will left the child with small bowel syndrome. So in such cases, second look operation after 24 to 48 hours is maybe reasonable, hoping for improvement in the intestinal blood supply after discussion with the family of the child. Number two, if complete mid-gut infarction is found, there may be two options: abdominal closure without bowel resection after intraoperative discussion with the family of the child. Number two, that however, the development of intestinal transplantations and the sophisticated visceral transplantation may make the best option in these cases less clear. Mesenteric thrombosis, it will happen after occlusions by the volvulus, and it may cause continuous intestinal ischemia. Recently, some authors recommend digital massage of the superior mesenteric vessels and post-operative systemic infusion of tissue type plasminogen activator to help to restore the intestinal blood supply. However, all these are under trials, under clinical trials, and not documented well up till now. Regarding laparoscopic approach, the laparoscopic approach described and the clinical outcomes have been generally been favorable in infant and neonates. The basics, what are the basic operative principles? The infant or the child placed supine, reversed Trendelenburg position. The surgeon stand at the child feet with the assistant and the nurse on the surgeon sides. Nasogastric tube is inserted. Then the umbilical camera port was inserted, insufflation from 8 to 12, depending on the age of the child. Right lower quadrant and the left mid-abdomen cannulas are inserted. This is working for the surgeon, and upper quadrant port to assess for retraction. This is the instrument for the assistant. In laparoscopy, the surgeon's first goal is to confirm the diagnosis, as different operative finding is reported in relation to the upper gastrointestinal imaging. So the surgeon's first goal is to identify the DJ junction and the ileocecal region and confirm that there is a malrotation of this intestine. The cecum in an abnormal position, the DJ in an abnormal position. Finding of the malrotation may include the high and medial cecal position, elongated and tortuous duodenum with abnormal position, malpositioned ligament of traits, presence of Ladd's band. The second goal is to assess the mesentery root length. This is a very important step. The root extending more than half the diameter of the abdomen is generally sufficient to prevent mid-gut volvulus. So during laparoscopic exploration, the surgeon must assess the mesentery root length. If the root exceeding or extending more than half the diameter of the abdomen, it is generally sufficient to prevent mid-gut volvulus, and some authors claim that Ladd's procedure are not necessary in such cases. However, no specific guidelines to suspect whether mid-gut volvulus will occur in the future or not. So it is still a debatable matter. Then further laparoscopic exploration should include identify and divide any obstructing duodenal band, identify and repair any internal hernia, and finally appendectomy, whether intracorporeal or extracorporeal appendectomy. So laparoscopy is very important for diagnosis and the treatment of intestinal malrotation. The first goal of the surgeon to confirm the diagnosis in relation to the preoperative imaging, identify the DJ, identify the cecal position, then assess the length of the root of the mesentery. If exceeding half the diameter of the abdomen, it may appear to be sufficient to prevent mid-gut volvulus, with taking in consideration the debate in this point, followed by identification of and dividing any obstructing Ladd band or duodenal band, identify and repair internal hernias, and finally appendectomy. There are also some laparoscopic challenge. The first one is the presence of mid-gut volvulus. During intestinal malrotation surgery, rapid intestinal detorsion is needed to rapidly save and restore the blood supply of the loop. This can be achieved by laparoscopy. However, the dilated bowel may cause difficulty in visualization and in the proper orientation of the surgeon. Also, dilated bowel may become injured by the laparoscopic instrument. The second limiting item in laparoscopy in case of mid-gut volvulus is the working space. The working space may be small by the dilated loops, may be small by the presence of the chylus ascites in the infant with acute mid-gut volvulus. So in this case, the surgeon should consider the option of conversion to laparotomy, which can be done by slightly extending the umbilical incision. So the first challenge to the laparoscopic surgeon is the presence of mid-gut volvulus. Although some papers described the laparoscopic technique in a 15-day neonate with mid-gut volvulus. However, most published papers for laparoscopic repair of intestinal malrotation are for infant with intestinal malrotations without mid-gut volvulus for elective cases. The second challenge, seen in older children with long-standing partial duodenal obstruction and internal herniation, the lattice band may cause the bowel to collect and form into what is called cocoon-like deformity. This may be a challenge for the laparoscopic surgeon to deal with these collected and adhesive together small bowel. The third challenge is the high risk of post-operative volvulus. Why? As we know that the formation of intra-abdominal adhesion is generally essential in the prevention of post-operative volvulus. In open surgery with direct bowel manipulation, it is straightforward that adhesion will form. However, in laparoscopic surgery with minimal manipulations, adhesion will be very minimal, like laparoscopic cholecystectomy and other laparoscopic procedure. So concern was raised about laparoscopic surgery for intestinal malrotation regarding the post-operative volvulus because adhesions are limited during laparoscopic surgery. So these limited adhesions may predispose this infant or this baby to develop post-operative volvulus, which may carry higher morbidity for this child. Regarding the post-operative management, nasogastric tube generally not needed in a straightforward cases without mid-gut volvulus. The bowel function usually return to normal in about 1 to 2 days with laparoscopic approach. In older patients with chronic obstructions, there is maybe prolonged ileus, and these children may need prolonged nasogastric drainage parenteral support. Also, post-operative antibiotics are not indicated in the straightforward and the simple cases without mid-gut volvulus or contamination. Feeding can be advanced per the surgeon decision as he wish. Infant with extended or subtotal bowel resection may need prolonged TPN until adaptation of the residual bowel happens. Regarding post-operative complications, 4 reported complication may be recurrent volvulus, may be post-operative adhesive small bowel obstruction, intestinal dysmotility, and post-operative intussusception. Regarding recurrent volvulus, the reported incidence less than 2%. The causes may be related to failure to perform the steps of the lattice procedure adequately, failure to straightening and freeing the duodenum is a major important factors in such cases. Failure to broaden the root of the mesentery may be also incriminated factor. Number 2, lack of sufficient post-operative adhesion formation, especially in laparoscopy. Post-operative adhesive small bowel obstruction, relatively common. About 10% of patients may develop post-operative adhesive small bowel obstruction, and the parent should be informed about this complication. Intestinal dysmotility. Some cases of continuous gastrointestinal symptoms in a small group of patients may be attributed to intestinal dysmotility after successful malrotation surgery. It is common in older children with less obvious preoperative abdominal pain symptoms as an indication for surgery. Finally, post-operative intussusception of the small bowel is a rare cause of recurrent intestinal obstruction, usually within the first and the second week after surgery. So this is the most common reported complication post-intervention for the treatment of intestinal malrotation. Now we will go to special consideration. some special consideration for intestinal malrotation cases. Number one, incidentally discovered malrotation. We mean by incidentally discovered malrotation that classic malrotation found incidentally at radiography or surgery for unrelated pathology in asymptomatic patient without any symptoms. The management of this patient is controversial. You perform investigation to diagnose another pathology or perform a surgery for unrelated, and you surprisingly faced with the presence of intestinal malrotation. Question arises here: to repair this malrotation, to correct malrotation, or to leave it as it is? On the other hand, you perform another abdominal radiograph and find malrotation. Do you interfere in the face of this radiological abnormality, or you leave it as it is? So the question arises for the pediatric surgeon, no doubt, whether incidental discovery of the malrotation in a child should be repaired. The answer may be, number one, regardless of the age, if the narrow base of the mid-gut mesentery is suspected, the child should have prompt corrective surgery. So if narrow base of the mesentery is suspected, surgery is the solution. Number two, some authors claim the principle of watchful waiting may be reasonable. However, there is criticism that about 20% of the patient undergoing operative repair for malrotation may have acute volvulus or bowel ischemia, and both are potentially life-threatening presentation. So principles of watchful waiting may not be appropriate in such condition. The third important solution is laparoscopy. And actually, laparoscopy plays a significant role in the management of asymptomatic patients with radiological evidence of intestinal malrotation. Many patients were found to have a narrow mesenteric base, which puts them at significant risk for mid-gut volvulus. So incidentally discovered malrotation in asymptomatic children may be a matter of controversy to the pediatric surgeon, and the pediatric surgeon must decide whether to use the repair if narrow mesenteric base is suspected, watchful waiting, school, or laparoscopy, and this is ideal for this group of patients. Both diagnostic can diagnose narrow mesenteric base and prevent subsequent risk of the mid-gut volvulus, and moreover, it will be therapeutic at the same session. Number two is atypical malrotation. What is atypical malrotation? Patient present with mild atypical symptoms, failure to thrive, recurrent and intermittent mild abdominal discomfort, and on imaging, the imaging studies was equivocal. What means by equivocal? That the finding not conclusive for malrotation. So that the DJ will lie in an equivocal position, not on the right of the spine, not on the left of the spine, not taking the normal position, however, just below the normal position. This child is usually named as malrotation variant. So this is atypical malrotation. Patient with mild symptoms, unlike incidentally discovered, the previous one. In incidentally discovered, the patient asymptomatic at all, and you find malrotation incidentally. However, in such case, the child may have mild symptoms, mild abdominal pain, failure to thrive, recurrent colicky pain, and when you perform imaging, the results of the imaging was equivocal. These equivocal cases also raise a dilemma for the pediatric surgeon to decide, number one, whether the symptoms are due to the radiological abnormalities, number two, whether to interfere in this case or not. So this is two major questions raised in the face of the pediatric surgeon in the cases of atypical malrotation. The decision may be close observation and repeat upper GI due to higher rate of the post-operative persistence of symptoms and increase in the post-operative complication in these groups of patients. The second option is laparoscopy, and it is ideal also for this group of patients to both confirm diagnosis and perform therapeutic LADS procedure. So the laparoscopy may be ideal for both groups. Children with incidentally discovered malrotation on radiological imaging performed for another region, number one. Number two, children present with atypical malrotation, mild symptoms with equivocal imaging studies. So the laparoscopy is ideal to confirm the diagnosis, to perform the LADS procedure. The third special consideration is malrotation with other congenital anomalies, such as gastroschisis and omphalocele, typically associated with rotational anomalies, usually non-rotation type, because the intestine is found in an abnormal site during the scheduled time for rotation. Or the second is anorectal malformation. Malrotation is more common in severe malformation, in severe types of anorectal malformation. In gastroschisis and omphalocele, the decision usually related to, number one, assessment for the risk of the midgut volvulus. Number two, some authors recommend concomitant LADS procedure at the time of the operative repair. However, this is still debatable items and not universally accepted. On the other hand, on anorectal malformation, the decision usually related to identification and the treatment of the malrotation and corrections at the time of the colostrum. However, it is very important in this group of patients is that appendix should be preserved for that potential future use as appendicectomy for anti-grade anemia. As all of us know that this group of patients may have later on problems with continence, and appendix may be used as an anti-grade enema to wash the colon. So please preserve the appendix in such a group of patients with anorectal malformation. As we know that the steps of the LAD procedures involve appendectomy at the final step. So if you can try to preserve the appendix, it will be better, as this child may need future anti-grade enema using the appendix as a conduit. The last one, or the last special consideration, is malrotation with heterotaxy syndrome. What is heterotaxy syndrome? It is abnormal arrangement of the thoracoabdominal organs across the left-right axis of the body, which means that the right side of the body will be mirror imaged on the left in right axis, heterotaxy, or the left side structures will be mirror imaged on the right side. It forms a special problem regarding the heart, the cardiac anomalies. Malrotation associated with heterotaxy syndrome in about 40 to 90% of these patients, about 2/3 of the midgut volvulus episodes occurs in these children in the first months of life, and 90% may present in the first year. As we see, the cardiac anomalies or the associated anomalies may be what's called left atrial isomerism and right atrial isomerism. You can observe that in such cases, the left atrium is mirror imaged on the other side, and there will be no right atrium with no or absent pulmonary veins. The liver will be midline and the stomach, and there will be polysplenia with malrotation. In right atrial isomerism, there will be 3-looped lung on both sides, right atrium mirror imaged on both sides, the liver midline, asplenia or absent spleen with malrotation. Sure that this left side isomerism and right side isomerism. In the right side isomerism, there will be obstructions of the pulmonary outflow and the pulmonary atresia. In the left side isomerism, heart disease may be relatively mild. The decision may be challenging for the pediatric surgeon. Number one, to obtain a screening upper gastrointestinal contrast study in children with heterotaxy syndrome or not. Number one, asymptomatic patient should not be screened for malrotation, and the American Pediatric Surgical Association recommend that there was a minimal evidence to support screening for malrotation in asymptomatic patient with heterotaxy syndrome. This is number one. The second challenge, to perform prophylactic LAD procedures or not. If symptomatic patient should undergo LADS procedure, however, asymptomatic children, the surgeon should balance the risk of the operative morbidity and mortality from the congenital heart disease versus the risk of catastrophic mid-gut volvulus. Some other authors base the decision on the type of the atrial isomerism. They claim that patient with right-sided atrial isomerism, operation recommended due to narrow mesenteric base and higher risk of mid-gut volvulus. Patient with left atrial isomerism suggested to be managed very expectantly or very cautiously. However, the recent review of malrotation in the pediatric heterotaxy syndrome determines that incidence of mid-gut volvulus at the time of the surgery will only 1.2. However, on the other hand, the post-operative complication rate, if surgery performed, will be about 14%, with 10% incidence of a small bowel obstruction. So these studies favor in the conservative or to avoid surgery for these types of patients. However, multidisciplinary approach involves the pediatrician and the radiologist, pediatric surgeon, cardiac surgeon are needed to make more definitive recommendation for this challenging group of patients. Also, it is crucial to include the parent and potentially the child as a part of the decision-making process. Finally, family discussion should include the risk and the benefit of the surgical intervention, as well as the risk and the benefit for the conservative management, which is very important. So at the end of this presentation, we need to concentrate on intestinal malrotation is a problem facing neonates and infants. Intestinal malrotation may be dangerous if there is a small distance between the DJ and the cecum, and there will be high risk for catastrophic mid-gut volvulus. Intestinal malrotation is the abnormality of the normal intestinal rotation. The abnormalities are very different, maybe incomplete rotation, maybe non-rotation, maybe reversed rotation, or paradiudinal hernias. The diagnosis of the intestinal malrotation is mainly clinical. Pediatric surgeon must have a high index of suspicion in any unit with sudden onset of bilious vomiting in a previously healthy unit must be considered as intestinal malrotation until proved otherwise. Investigation or investigatory tools may be helpful in a stable child. There is maybe plain X-ray to show the distribution of the gases. Upper contrast study may be helpful to identify the duodenal pattern of malrotation, to identify the presence of the mid-gut volvulus by the diagnostic criteria corkscrew, paired peak appearance or Z-shaped configurations. The ultrasound is diagnostic by the inversion relationship of the superior mesenteric vessels and vein. However, this is maybe normal variant with normal malrotation, and also the vice versa, maybe the normal relation may be present with intestinal malrotation. Finally, after the diagnosis, there will be a procedure described as it is since 1931 and 36 by LAD, which is called LAD's procedure, starting with eviscerations and the detorsions, followed by straightening and freeing of the all adhesion of the duodenum, starting with broadening of the mesentery of the intestine, leaving the small bowel on the right and the colon, large bowel on the left, like the state of the non-rotation, and ended with appendectomy. There is be some challenge to the pediatric surgeon, whether related to the viability of the intestine or related to the complete necrosis of the intestine. Actually, and recently, laparoscopy play an important role in the infant and children with intestinal malrotation. The laparoscopic will perform both diagnosis and both the corrective surgery. Laparoscopic challenge may be in the cases of the mid-gut volvulus. Laparoscopic challenge may be related to long-standing cases with adhesion of the intestine. Also raise concern of laparoscopy about the formation of post-operative adhesion that will prevent the post-operative volvulus or not. And finally, we must not miss the special consideration, what's called incidentally discovered malrotation in a previously healthy child with no symptoms at all, discovered whether intraoperative or on radiology. In this group of patients, the best option is to do diagnostic laparoscopy to confirm the diagnosis, assess the length of the root of the mesentery, and perform corrective surgery. On the other hand, you may find atypical malrotation, a child with vague abdominal, non-specific symptoms, and also the imaging will be equivocal, not conclusive to support your diagnosis. In such cases, it is better to use laparoscopy also to define and document the statement of the DJ and the seeker. And finally, other associated anomalies, gastroschisis, anorectal malformation. In gastroschisis, you must assess the length of the mesentery. Also, in anorectal malformation, it is important to leave the appendix for the future use as an antegrade continent device or conduit, for as many of these children may have continence problem. Finally, infant and the children with heterotaxy syndrome, which is a right and two left axis body disturbance of arrangement of the structures. This may put the pediatric surgeon in a challenge to screen for malrotation at first or not, to perform prophylactic LADS procedure or not, and there is a debate. And finally, you must include the family and include even the child, if you can, in the decision making with the risk and the benefit of surgery, and explaining also the risk and the benefit for the conservative treatment. Thank you very much for your attention, and see you next subject of pediatric surgery made easy. Thank you very much.